Thank you very much, Augustine. And thank you very much to the French Cardiac Society for having invited me. I'm very sorry, I have to declare that I'm very bad with languages. It cost me quite a while to speak more or less good English, and I lost my Spanish and my Catalan, so no way I'm going to try to another language. So these are my disclosures. And when I have to speak about quantification and mechanisms of tricuspid regurgitation, I always like to start with this slide and with the guidelines. And I have to say that I was part of that task force of the guidelines. And every time that I look at this algorithm is something that strikes me quite much, because when we go to this algorithm and we start with the management of tricuspid regurgitation, the first question we need to answer is if there is a need for left-sided valve surgery. Who asks for a left-sided valve surgery if you want to look at the tricuspid valve? Why do we need to ask for the left-sided? It doesn't make sense to me. And this is because the left-sided valve diseases are more frequent, or they have been usually put much more attention to, and they are considered that they are kind of more life-threatening than the tricuspid regurgitation. And if we are going to embark on that, then we look later on to the tricuspid regurgitation in case we need to do something preventative or something that need to be repaired. But in case there is no need for left-sided valve surgery, then we check the severity and the etiology of tricuspid regurgitation. That is more or less the same than saying as well the mechanisms. And basically the guidelines divide in secondary or primary. And then we look for the right ventricle function and for the symptoms. So in summary of this algorithm, there is no need for symptoms of severity of TR as a first question. It's much more the left-sided, which for me doesn't make sense. And then we check in order to decide what to do on how is the right ventricular function. So how are we going to assess the severity of tricuspid regurgitation? This is the algorithm that the European Association of Cardiovascular Imaging recommends. And many people now, because we have also trials, try to quantify. But before you go to a quantitative evaluation, there is this in small letters, but actually you should go first to this step, where you have already probably severe tricuspid regurgitation and you can skip the quantitative evaluation if you have qualitative parameters that indicate that probably it's going to be severe, such as flail leaflet or a large coaptation defect or a severe tenting of the leaflets with a very large central jet, with a very large holosystolic convergence zone, or with a dense and triangular continuous wave Doppler jet with early peaking. You have even semi-quantitative parameters such as the PISA radius of at least 9 millimeters, the vena contracta width of at least 7 millimeters, and the hepatic vein systolic flow reversal. And then you have structural such as the right atrial and the right ventricle dilatation. If you have 4 or more of these, you can already consider that this is severe tricuspid regurgitation. You don't need to go to quantitative evaluation. They recommend to go to quantitative evaluation whenever possible, and particularly when there are many discordant parameters here. And then you have the effective regurgitant orifice area, the regurgitant volume, and the regurgitant fraction. Now, it's very important that you indicate the loading conditions of the patient. Whenever we are going to assess the severity of tricuspid regurgitation, make sure the patient is in the more dry weight as possible, and also test the response to diuretic treatment. And some key points regarding the PISA for the quantification. The guidelines or the recommendations of EACVI, they say when feasible, the PISA method is the best to quantify the tricuspid regurgitation severity with a PISA radius of at least 9 millimeters at an equus limit of 28 centimeters per second. And an effective regurgitant orifice area of at least 40 square millimeters and or regurgitant volume of at least 45 milliliters indicates severe tricuspid regurgitation. And then, once you have done the severe tricuspid regurgitation, it can be subcategorized into severe, massive, and torrential, and we will explain that. And then when there is doubt, the guidelines also recommend whenever possible to use the 3D echo and probably the three-dimensional vena contracta area, which is much more an anatomical area, would be in my opinion, better, or CMR. And I wonder, how many of you have tried to use the PISA to quantify the tricuspid regurgitation? How many of you do it in clinical practice regularly? I'm much more of the opinion sometimes of Hector Michelena in Mayo Clinic that says that PISA means, please, I can't stand it anymore, because whenever I try to calculate it, it gives me a number that doesn't make any sense to me. So I think that 3D echo probably is much more reliable. At least I can measure the regurgitant orifice area, the anatomical one, but at least I can see it. And with the PISA, I don't know which calculations I do to try to rely on an hemisphere coming from a valve that usually has at least 3 leaflets and is not going to give me a circumference orifice area. Now, whenever it's severe, then you have to consider massive and torrential. And that came because the patients that we see now that we put more attention to the tricuspid regurgitation are patients that have been severe for years, and now they come with this massive and torrential. And of course, if you have a valve that is not working properly, that is not providing a good preload to the left ventricle in order to keep the cardiac output, you are going to have a patient that is in worse condition, and that is associated with worse outcome. Now, this classification, it goes very well to new therapies. Why? Because if I can reduce at least 2 degrees of tricuspid regurgitation, I'm kind of effective. Yeah, you reduce from torrential to severe, you gain something. But is that enough to reduce or to improve the outcomes of that patient? That's a question that the trials are trying to demonstrate, and we need to go to the win-win ratio in order to show that these therapies are effective. And more important, now that we have the transcatheter therapies, probably we need to also look at the etiology, because it's not the same the tricuspid regurgitation that comes in a congenital heart disease, in an organic disease, in a left-sided valvular heart disease, or pulmonary hypertension. And this is why the group of tricuspid regurgitation in PCR tried to come with a kind of a standard terminology to define the mechanism of tricuspid regurgitation. We can have the functional or the secondary, yes, when the leaflets and the subvalvular apparatus are kind of intact, but functionally are not okay or not coapting okay because there is a dilatation of the right atrium, and there we will not have so much stenting on the leaflets, but there is a coaptation gap because the annulus is too wide. Or ventricular, when we have dilatation of the right ventricle and we have much more tenting of the leaflets. Then we have the tricuspid regurgitation related to the presence of pacemaker. And then we have the organic or the primary, which could be, for example, a carcinoid syndrome or any other disease. Now, here there are the 4 examples. And I have to say that for the ventricular one or the atrial one, sometimes it's difficult because they come, the patients, at the same situation where everything is dilated. The one device-related is easier to define, particularly when there has been one lead that has been removed and you have a prolapse or a flail. And then you have the carcinoid when you have the leaflets completely thickened and retracted. But of course, the therapies that we have now are not the same or are not valid for all of them. There is one for each, or this one device for each lesion. And this is where we need to have a very good anatomical assessment of the tricuspid valve in order to make sure that the device is going to be effective. The first one is to define, for example, the number of scallops, and that comes particularly when we are attempting an edge-to-edge repair, which is probably the most available one, the one that has the largest evidence and which is very safe. And we know that there are anatomies that are more suitable for that device, particularly when there are the 3 leaflets and there are not so many scallops in each of the leaflets as in the classification of Becky-Hahn. If we have a 3D, it's kind of easy, but sometimes we don't have a 3D or the window is not that optimal, and then we have to rely on 2D. And I think that it's good to spend time to analyze the tricuspid valve anatomy, to assess the mechanism with 2D. And there you have the different 4 views in order to assess the mechanism, and also particularly useful when you have a pacemaker. You have, for example, the basal short axis with a single leaflet where you see the anterior leaflet. You have the apical view with the coronary sinus, which is much more posterior, and you have the septal and the posterior leaflet. You have the apical 5-chamber view, where you see much more the aorta, and you have the septal and anterior leaflet. And then you have the parasternal long-axis view with the right ventricular inflow view with the septum, where you have the anterior and the septal leaflet. I think that that's a good exercise to properly assess the tricuspid valve. Of course, if you have 3D, it's easier, and I recommend you to go through all the different views in order to assess the suitability to guide the procedure, because not only the anatomy needs to be assessed, also which is the quality of the window in case you want to embark with a transcatheter therapy. And we have now softwares that are more automated that can allow us as well to measure the annulus and serve as a kind of gatekeeper for other devices where we are going to need a CT or a CMR. Important to assess the right ventricular function, particularly if we are going to go for surgery. And remember that the right ventricle has a crescent shape with an interventricular dependence through the septum, and there is no continuity between the tricuspid valve and the pulmonic valve, so that makes the tricuspid transcatheter replacement more achievable or more feasible than the mitral valve, and probably more effective in terms of eliminating the tricuspid regurgitation. But in this case, I would recommend to do a 3D evaluation, either with CMR, because it's kind of the reference standard to assess the right ventricular function. And it's always important to recognize that this is a right ventricle overloaded in terms of volume, and probably why we are overestimating that function, whether we use strain or 3D. And new techniques, such as, for example, the invasive measurements, can be more helpful when we have doubts. Now, for me, in conclusion, the assessment of tricuspid regurgitation is important. It should be done with the patient as dry as possible, and recognizing a severe tricuspid regurgitation, those that are before those that are massive otorrhynchial, because going to massive otorrhynchial have prognostic implications, and don't be afraid of indicating in the report that this is a severe tricuspid regurgitation. And there are now more therapeutic approaches than ever, but in order to select wise and to make sure the outcome of the procedure is going to be good, you really need to have a very good assessment of the mechanism and the tricuspid valve anatomy. And do not forget the right ventricular anatomy, because that is also important. And with this, I would like to thank you for your attention. And if you are thinking for the next year at the end to come with us at EACVI, you will be always very welcome. Thank you very much for your attention.